This newsletter and podcast episode are for educational purposes and not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment for yourself or others if you are a practitioner. Please consult your physician for any medical issues you may be having. Welcome to the Holistic Psychiatry Podcast. I'm Courtney Snyder, a physician and holistic adult and child psychiatrist. In this episode, I'll be discussing OCD, or Obsessive Compulsive Disorder, and nutrient-based therapies. Obsessive Compulsive Disorder is a debilitating condition that involves intrusive thoughts and time-consuming repetitive behaviors. Because many of you listening are already familiar with OCD, I won't be describing the condition as much as spending this episode on discussing treatment specifically using targeted nutrients. So OCD impacts 80 million people worldwide. This would be 2 to 4% of the U.S. population and 1 in 100 people here in the U.S. It can be difficult to overstate the suffering caused by OCD, not only for those with the condition, but also for their family members. In addition to the distress caused by obsessional thoughts and compulsions, there can be a great deal of shame and loss of meaningful, purposeful, or pleasant thoughts and behaviors. There is also the loss of time spent connecting with others or engaging in purposeful and enjoyable activities. Other conditions associated with OCD include body dysmorphic disorder, skin picking, trichotillomania, which is hair pulling, hoarding, hypochondria, and olfactory reference syndrome. So this is an irrational feeling or belief that one is emitting a foul smell and then making attempts to remove the odor. It's not unusual for someone with OCD to have other conditions, such as other forms of anxiety, depression, ADHD, autism spectrum disorder, eating disorders, or Tourette's. Research suggests that having OCD raises one's vulnerability to developing dementia in the future. Many other brain conditions, however, also appear to raise this vulnerability similarly. Treatment challenges. OCD can be especially challenging to treat. 60% of those with OCD do not respond to typical therapies, which often include cognitive behavioral therapy in combination with medication. Examples of medications used include SSRIs, or selective serotonin reuptake inhibitors. These are medications such as sertraline, fluoxetine, fluvoxamine, citalopram, and paroxetine. Tricyclic antidepressants such as clomipramine have also been used, as have SNRIs, or serotonin and norepinephrine reuptake inhibitors, such as venlafaxine. Atypical antipsychotic medications are also sometimes added, especially if someone's symptoms are particularly severe. Again, the medication is typically combined with cognitive behavioral therapy, which involves exposure and response prevention, or sometimes CBT is used alone without medication. So as you might have noticed, most of the medication approaches are aimed at increasing serotonin activity. Serotonin, however, is just one of the neurotransmitters involved in OCD. What has become increasingly clear through research is that OCD also involves abnormal activity at the NMDA receptor. This is a glutamate receptor that is gaining a lot of attention in psychiatric research. NMDA and glutamate. The NMDA receptor is found throughout the brain. Glutamate is the main excitatory neurotransmitter in the central nervous system, and it binds to the NMDA receptor. NMDA and glutamate are involved in synaptic plasticity, so the creation of neuronal connections. NMDA and glutamate are also involved in learning, memory, and motor function. So presynaptic neurons, so these are neurons, a neuron before the synapse, which is the space with which chemical communication occurs between cells, These presynaptic neurons release glutamate, which binds to the NMDA receptor on the postsynaptic neuron. This results in a cascade of signaling events that lead to neuronal excitation. The problem arises when this receptor has too much, or in some cases, too little activity. So with OCD, there's too much activity at this receptor, and thus too much neuronal excitation. So dysregulation of the NMDA receptor appears to play a role in OCD, but also depression, PTSD, schizophrenia, bipolar disorder, and substance use disorders. Weak memory extinction can result from high activity at the NMDA receptor. So while memory is a good thing, even with memory, there can be too much of a good thing. And this can look like thoughts getting stuck. So in OCD, for example, this could be intrusive thoughts. With PTSD, this could be flashbacks. With psychotic disorders, this could be delusions or false beliefs. And with addiction, these thoughts getting stuck could be in the form of craving. So again, the term here is weak memory extinction, results from high activity at this NMDA receptor. Lastly, neurodegenerative disorders such as Alzheimer's, Parkinson's, and ALS have also been associated with NMDA receptor malfunction. Methylation and NMDA. Those who are undermethylated, especially those with OCD or addictions, have high activity at the NMDA receptor. And to remind you, undermethylation is a biochemical process with many jobs, including the breakdown of histamine, the support of detoxification, and optimizing serotonin activity. So when someone is undermethylated, they can tend to have allergies, be perfectionistic, competitive, strong-willed, have obsessive compulsive tendencies, or as the case I'm talking about here, obsessive compulsive disorder, though someone doesn't have to have OCD to be undermethylated. There can also be a tendency towards being ritualistic, having dietary inflexibility, and often with these individuals, or at least within their families, there can be a history of high accomplishment. Not surprising when you think about perfectionism, competitiveness, somewhat being detail-oriented, how that can contribute to high accomplishment. Undermethylation, again, contributes to low serotonin activity seen in OCD, but again, simply addressing undermethylation, just like merely addressing serotonin, will only bring partial benefit because of that NMDA receptor. To address undermethylation, we do use SAMe, andromethionine, B12, B6, magnesium, and antioxidants. And for those who have a high homocysteine, we address that before addressing methylation. But again, this doesn't get to the NMDA receptor. So how can that be addressed? Blocking NMDA and normalizing glutamate activity. Esketamine or ketamine, which has been getting a lot of attention in recent years, can impact the brain in various ways. However, its primary mechanism is as an NMDA blocker or antagonist. For some, ketamine can serve as a rapid-acting and highly effective antidepressant. It can also decrease OCD symptoms. Other NMDA blocking drugs include memantidine and dextromethorphan combined with bupropion. Lamotrigine can decrease glutamate release and has been used as an adjunct medication for OCD. However, nutrients can play an important role at the NMDA receptor, and so that's what I'll be focusing on here. NAC, or N-Acetyl-Cysteine, is a precursor to glutathione, and thus an antioxidant. It also has anti-inflammatory effects and is a binder to a particular toxin made by both Candida and mold. But it is also an NMDA antagonist or blocker, so it decreases activity at that NMDA receptor. And again, high activity at that receptor can convey symptoms of OCD and or addiction, or for some, flashbacks or even delusions, depending on the condition. NAC has been shown to reduce obsessions and compulsions of OCD. It has also been studied in alcoholism, opioid addiction, cocaine abuse, gambling disorder, shopping disorder, cigarette addiction, and trichotillomania. It has been used by itself and as an adjunct therapy to medication. From a Walsh perspective, again, we use the Walsh nutrient protocols to address things like undermethylation. NAC has become part of the undermethylation protocol for those with addiction and/or OCD. And I would note too, while addressing undermethylation is important, addressing pyrroles is important as well if that is present. Because when someone has elevated pyrroles, they can have low zinc, which I'll talk about, but also low B6, and we need B6 in order to make serotonin. So again, when we think about OCD, we think about problems with serotonin activity and problems with the NMDA receptor or glutamate receptor. So aside from NAC and addressing methylation and addressing pyrroles if present, the other consideration would be zinc, because zinc also plays a role in regulating functioning at that NMDA receptor. The Walsh Research Institute found that 90% of those with brain symptoms had relatively low zinc. The way we dose zinc is determined through testing of a plasma zinc, and we use a particular range called the Pfeiffer-Walsh range that is different from a typical lab range. Zinc has been found to improve the treatment response of those with OCD who are treated with SSRIs. Inositol is used in the serotonin and glutamate signaling systems. It too has been found to be beneficial. However, it requires very high doses. The challenge of research, as you can see, is that each of these approaches are looked at in isolation, as opposed to, for example, addressing undermethylation, optimizing zinc, addressing pyrroles, and using targeted nutrients such as NAC and inositol to address the NMDA receptor. Candida and mold. Aside from undermethylation, low serotonin activity, and high activity at the NMDA receptor, those with OCD appear to have high oxidative stress, as is the case with most with brain-related conditions. One of the more common sources of oxidative stress that I see clinically is Candida overgrowth in the GI tract, which often follows antibiotic exposure, and mold toxicity due to exposure to water damage, which can be caused by seen or unseen toxic mold. Because mold and Candida or yeast thrive on sugar and a high carbohydrate diet, there is often a fluctuation in symptoms with sugar and carb intake. How might these intersect with the NMDA receptor? Well, mold and yeast can contribute to high histamine states, and histamine can increase activity at the NMDA receptor. And though I focus on Candida and mold because they're so common, any biotoxin, whether it's from Lyme, Bartonella, Babesia, could also be contributing to high histamine states and aggravating the NMDA receptor and thus OCD symptoms. I'll comment too on estrogen. For women and teen girls that I've seen with OCD, there's often fluctuations in their OCD symptoms. Typically, their symptoms worsen during the times of the month when estrogen is at its highest. Estrogen does appear to increase activity at the NMDA receptor. PANDAS and PANDAS. When a child has an abrupt onset of OCD symptoms, PANDAS and PANS should be considered. So PANDAS is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. So this will be where a child has had a strep infection, and then shortly thereafter, they'll develop an acute onset of OCD symptoms. And this is because the immune system, which is basically going after strep, is antibodies are acting on a particular part of the brain causing the OCD symptoms. PANDAS is similar, though not specific to strep, and this is pediatric acute onset neuropsychiatric syndrome. These are considered autoimmune conditions, meaning the immune system is acting on the body, or in this case, the brain, and specifically the basal ganglia. Other symptoms can include restricted eating, mood symptoms, regression in academic or social skills, and motor tics. While triggers are often microbial, such as viral, bacterial, strep in the case of PANDAS, or other microbial sources, what is often underlying the dysregulated immune response, in my experience, is mold toxicity. So again, at the deepest level can be mold toxicity, and even low zinc can contribute to immune dysregulation. Then above that could be a dysregulated immune response to a microbe that's then activating the immune system in a way that's causing the OCD symptoms. So to summarize, because OCD can be difficult to treat, with about 60% of people who may not respond, it's important to consider other facets of treatment, and specifically this NMDA receptor. So I would argue, and much of where I've gained this information is through Dr. Walsh and the Walsh Research Institute, I would argue that addressing methylation, optimizing zinc, and decreasing activity at that NMDA receptor using targeted supplements, or in some cases medications may be warranted, can be very important. I would also say that lowering histamine and addressing sources of oxidative stress, whether that's trauma, chronic emotional stress, toxins, inflammation, are also important. And if a woman is dealing with estrogen dominance, that may also need to be considered. Thank you for listening. If you'd like to help me get this information out into the world, please consider sharing. If you would like to receive these episodes in your mailbox each week, please consider subscribing at CourtneySnyderMD.com. I look forward to connecting with you in a future episode. Until then, take care.